recording. I'm just going to leave that right there. And move all this stuff out of the way.
Are we all set?
Let me just make one more call down to the master control.
Okay.
Hey Dan, it's Dave. Are you recording the geriatric man rounds today? Okay. Probably not. Yeah. Okay. All right. Then we're set. Okay. Thanks. All right. Bye. Okay, Victoria, you're all set.
Okay. Thank you, everybody, for being patient with us. And thank you for joining us for today's Geriatric Grand Round program. This program is provided by the Michigan Center for Rural Health in cooperation with MSU College of Human Medicine and the MSU College of Nursing. Before we begin, please remember to keep your mic muted until the Q&A component at the end of the presentation. Please remember to mute your mic after you've asked your question so the signal is clear. Handouts are located on our website at www.mcrh.msu.edu. Click on the education link across the top of the screen, scroll down and find today's date, and then there you will see the presentation, the attendance forms, and the evaluation link. Continuing education is available for physicians, nurses, and social workers. Each healthcare discipline has their own attendance form or sign-in form, and everyone fills out the same evaluation by clicking on their link and completing it in SurveyMonkey. However, physicians, please note that you have a whole different process. If you have any questions, please let me know. These forms need to be emailed, faxed, or mailed into the Michigan Center for Rural Health office no later than September 20th. Our speaker today indicates no conflict of interest, and the planning committee did not have any conflicts. There is no commercial support for this program. With that, I am pleased to introduce Dr. Ann Hughes, who will be speaking on the early insights into improving transition for stroke patients. Go ahead and take it away.
All right, thanks everybody. Appreciate you being here. I'm gonna just quickly go through a couple of the early slides because I don't want you to lose time here. I just want to acknowledge our funders. We are funded by PCORI, which is Patient-Centered Outcomes Research Institute. So a lot of the information I'll share today came from a project that they funded. Today we're going to go over some of the models for care transition that are currently being used in the United States. I'm hoping you will, after the program, have a better understanding of the range of challenges that stroke patients and their caregivers experience when they're leaving a hospital after an acute stroke. And then I'd like you to be able to identify a couple of practice behaviors that you can implement in your practice to improve the transition. As background, some information about stroke in the United States. We're almost at 800,000 strokes per year. A quarter of those are recurrent strokes, and the vast majority are ischemic strokes, which are the strokes caused by a blocked blood flow to the brain. The other, second most common, is a hemorrhagic stroke. It is the leading cause of serious long-term disability in the United States. We have close to 5 million survivors in the community, half of whom need some assistance in either their activities of daily living or their instrumental activities of daily living. Some of the things we know about stroke survivors is that after a stroke, many feel a loss of confidence, a loss of independence, and a loss of self. And the caregiving experience has been characterized as stressful and burdensome. Stroke is not predictable and characterized by a rapid onset. So that creates some unique challenges for patients and caregivers. Contrast that with other chronic illness where you see some progression and you have some notice that things are getting worse. Because of the quick onset of a stroke, many patients and caregivers are completely unprepared to manage the acute stroke. Spouses have said that they actually experience grief after a stroke due to the loss or shift of their roles, as well as the loss of their relationship with the partner. When we're thinking about healthcare transitions, this is a very broad term. It can be used to think about internal transitions, so transitioning between levels of care within an institution. Also, we can think about movement between different types of facilities or care locations, such as a skilled nursing home or the home setting. They're typically associated with high risk, particularly for people with complex healthcare conditions such as stroke. Unfortunately, much of our conversation about care transitions has been about cost. And that tends to be the emphasis, is that people want to focus on transitions to reduce cost. I personally think there are a lot of other areas we should be targeting when we think about improving care transitions. And it's certainly something that patients and caregivers are interested in getting involved in improving. Why is there interest currently? So we do know that hospital stays are getting shorter and shorter. There have been important changes to the reimbursement model so that hospitals and healthcare facilities are really being targeted around readmissions. We also see on the flip side some greater integration for in-hospital and post-hospital services. Sometimes that's pushed by these reimbursement models. We also are seeing some advocacy among patients and caregivers to get some more assistance after discharge. This can be very challenging for patients and caregivers. And one of the things that I'm particularly interested in are the psychosocial barriers that accompany transitions. And it's thought that many of the breakdowns that cause readmission are actually related to psychosocial concerns, as well as clearly physical or functional concerns. When we think about hospital-based stroke care, again, we're looking at a very short hospital stay. So the average length is 4 days. This can be really characterized by a number of things for patients and families. It's been called a time of crisis. When you think about all the information that families have to absorb in this very short amount of time, it can be very overwhelming for them. And we find that a lot of times patients and caregivers are not in a place where they can absorb information. So we hear from providers that patients are pretty, given some really great information at the hospital level. But they then get home and kind of forget what they were given or misplace what they were given. And we feel like they're really, there ought to be opportunities along the spectrum to learn some of this information. So they may not have the ability to process or retain information that we're giving them during the hospital stay. As well, stroke really follows a complex path, and transitions can represent major challenges as well as opportunities. We do see a lot of variety in stroke recovery based on severity, pre-stroke function, age, and certain social factors. So it certainly is not a one-size-fit-all experience when someone's transitioning home from a hospital after an acute stroke. I'll describe the lines on this graph because I imagine it might be hard to see, and obviously the colors are not showing up on the handout. What we're looking at here is kind of the trajectory of what happens to folks when they leave the hospital. So the top line is the 50% approximately patients who return home directly without services. So that's a pretty nice proportion of patients. And then if you go down, you'll see the next line is the percent that go to inpatient rehab facilities. The next line is patients that go to skilled nursing facilities. And then the bottom line are the percent that go home with some home care. So that hovers around 10 or 11%. The challenge when folks get home is that oftentimes they don't really know what they don't know. So things function pretty well in the hospital, but then they get home and they can't maneuver around their home in the same way, or they can't take care of themselves in the same way. Sometimes these challenges did not present themselves in the hospital. Now, if you've been to an inpatient rehab, sometimes you're getting help with some of the self-care and negotiating showers and things like that. The folks that are returning straight home without services, however, oftentimes are left in a bit of a pinch, and then they're faced with the obstacle of trying to figure out how to arrange services themselves once they get home. So there have been a lot of people thinking about how could we improve this transition experience. Again, not specific to stroke, but really looking at care transitions broadly. And there's been some data on the use of coordinated care management programs to improve the transition home. There's also been some work done on using e-health technologies to improve communication, thinking that if we could improve communication between levels of care, that might help the patient be more successful. And then putting the onus on the patient a little bit more. Could we improve their self-management? Could they be much more active in the care for their stroke or other chronic illness? So things like access to information, patient activation activities, greater patient engagement. So you'll see I'm going to go through some of the current transition programs that we have here in the U.S. As a group, they typically focus on the transition from hospital to home. So I'm not going to review programs that look at transitions between, say, hospital and a skilled nursing facility. The programs target a variety of populations, so not necessarily older patients. They often will target folks that have a higher risk profile, so some of them do a count of comorbid conditions. Some of them do a count of hospitalizations in the last 90 days. So they have different criteria for who they pull into their programs. But you'll see they offer a range of services. So some of what we had talked about earlier, this enhanced communication. So can we help people communicate better with each other? And then there is some programs that use in-person visits. Many programs do follow-up phone calls. And these services are provided by a range of professionals. And you'll see when I highlight some of the sample programs, just how there's a lot of variety in these programs. So you may have heard of the transitional care model. It's a very popular model in the U.S. We also have the care transitions intervention. Re-engineered discharge, or Project RED is typically how people know about it. There's also a program called Enhanced Discharge Planning Program, where services are increased around discharge planning services. Specific to older adults, we have the BOOST program, which is better outcomes for older adults through safe transitions. And then we have the BRIDGE model, which uses a social work model to help bridge people from hospital to home. As I said, there's a lot of variability in these programs. So they range from 30-day programs, 90-day programs. They also range in intensity, so how much contact the programs are having with the patient or with the family. And the staffing is different. So some of them are staffed, transitional care model uses an advanced practice nurse as the interventionist. Others use discharge planners, and some use, as I said, a social worker. So when programs are taken up by organizations, so say your local organization wanted to use the transitional care model, what we're finding is it's very typical that programs personalize or localize the intervention. While that's great for the program itself because you've evaluated what needs you have, it actually creates some challenges for evaluating the intervention itself. So if you remember way back to your research courses, we like to see consistency or fidelity in how a program is administered. And it's hard to compare programs where the local site has changed some of the what we call active ingredients of an intervention. So we'll see across the board with care transitions programs that the evaluation process can be quite challenging because programs are changing things based on their individual needs. And so in a certain sense, that challenge does slow the kind of scientific progression of this field. But I think if we think about practical issues related to practice, organizations really have to respond to their local community and what you already know. You all are the experts on what's happening locally, how you feel the program will fit best for you. So as researchers, it's always hard to balance that, but I come from a practice background myself, so I certainly understand the need to localize the program. So when we look at outcomes, are these care transition programs making a difference? And we see that there's data on some of them. So the big push has been on reducing readmissions. There's actually strong evidence that the transitional care model and the care transitions intervention, as well as Project RED, have been effective in reducing readmissions. So the range there is a 19 to a 70% reduction. So, clearly there's a spectrum of results. They all have different follow-up periods, however. So it's not, you can't exactly compare them. The transitional care model is the only one that found long-term effects on reduction of readmission. They did a 1-year follow-up. And at the end of that year, they found that the model had reduced readmissions by 36%. So we consider that very strong evidence. There's also some suggestive evidence that there are effective program components across these different care transition programs. The ones that are suggestive of being positive or contributing to positive outcomes is a duration of longer than 9 weeks. So the 30-day programs were less effective than the ones that were longer than 30 days. Also, the use of nurse case managers was an important factor in the success of these programs. And not surprisingly, the multiple component programs they were much more effective than the programs that really had 1 or 2 components. And when you think about clinical care and particularly complex care, a lot of these folks are complex patients, it makes sense that the multiple components really meet people's needs in a different way. So what can we conclude about these care transition models and programs that are currently in the field? There's absolutely a will and an interest in solving the transitions challenge, and that there are many promising interventions available. They do come with the challenge of replicating them and ensuring that you're actually following the intervention as it was written. However, there's much more work to be done. We identified that there were no programs that focused on stroke. As that was our interest, we began to think about, okay, how could we develop a transition program that was specific to stroke patients? And in addition, we wanted to see if there was a way that technology could contribute to easing this problem. So this led us to develop the MISTT study, which stands for Michigan Stroke Transitions Trial. And I'm going to share with you a little bit about that study and then share with you some of our early findings about how we are making a difference in the transition experience. So I am one of many. Obviously you can see there are many investigators, School of Social Work, Department of Epidemiology, Communication Arts and Sciences, and Outreach and Engagement. We were funded in 2014 by PCORI for 3 years. And this is just the title of our funding. We wanted to improve care transitions through a patient-centered, home-based case management program. If you're not familiar with PCORI, it's actually a really interesting agency. It is funded by the federal government through the Affordable Care Act. And it was developed to look at research and do research differently. So the outcomes that they are interested in are decided by patients and caregivers and families and what they call stakeholders. So they want to fund outcomes research on issues that are important to patients as well as clinicians and the community. So they function slightly differently than some of the other funding agencies. But they have a great website if you're interested, particularly in patient-centered research. They've done a tremendous amount of work there, and they're an interesting organization. And I think as I go through some of the study details, you'll see how that funding organization really did impact how we did our work. So I'll go through our study aims with you. We had 3 of them. Our first aim really encompassed a year's worth of work. We were charged with assembling 2 panels of stakeholders, one recent stroke survivors and their caregivers, and the second healthcare providers. So you'll see we pulled together a very interdisciplinary group of providers to help us understand what stroke patients need, what their families need, how could we improve the transition experience for them. So when we talk to stroke survivors and patients, we really question them about their experiences, how it could have been improved, what made an impact for them, and what they would have wished they had when they transitioned after a stroke. The healthcare providers really helped us understand what usual care looks like in the stroke world in our communities. So we studied the Lansing area and the Ann Arbor area here, and we wanted to find out, okay, what's typical of discharge from a hospital to home? What do you provide for patients? How do you follow up with them? What sort of support services do you provide? While there were some differences if people went to an inpatient rehab or a skilled nursing facility, overall the conclusion was that usual care was really, there wasn't much there. So people were not getting a lot of support in their transition home. What did the patients and caregivers tell us? So again, this is aim 1, and this really was the foundation. And again, it speaks to our funding agency that we wanted the work that we did to bubble up from patients and caregivers. We wanted them to be our partners in developing this program. So I'll share with you some of what they said. Again, we did a series of focus groups. I believe there were 4 in both locations. This transition home is a time of confusion, loss, and upheaval. Patients and caregivers feel unprepared despite the education they're given while in the hospital. Their information needs exceeded what was provided, particularly in their need for personalized information. So a lot of emphasis on why did I have this stroke? What does my stroke look like? And really wanting information about their particular risk factors. Fear of reoccurrence and stroke prevention were primary concerns for all focus group participants, whether they were patients or caregivers. So you'll see that theme recur in a lot of what we move forward with. For many, this was their very first experience trying to access multiple healthcare services, and coordination was a challenge for them. More information regarding challenges to anticipate once home was desired by both patients and caregivers. So could you have helped me anticipate what I would have needed? Again, we think about the complexity of stroke and recovery, and it's hard to do that because we don't necessarily know exactly what someone's going to encounter when they get home. But it speaks to this idea that they really felt unprepared. Couples, so we talked to a lot of caregiver patient couples. They faced a lot of unanticipated psychosocial challenges, a loss of support. So we heard some very sad stories about folks who family and friends really did not reach out to them and did not provide help when they felt they needed it. And many of them actually had a loss of some friendships or even family. They were experiencing role confusion. So when you think about couples, we kind of just bump along doing our normal thing, and I have expectations of you and you have expectations of me. Suddenly we have this kind of crisis event, and one of us can't do what we used to do, and so now I'm not sure what my role is and you're not sure what your role is, and that was a challenge for folks. They talked about it on many levels, from the very practical of like, oh, you know, she used to always pay all the bills, now I have to figure out how to pay all the bills. Or, you know, he was my driver, and now I have no way to get out of the house. So although the stroke affected him, I now am much more isolated than I used to be. And then this idea of labile emotions. So folks not being prepared for how up and down emotionally people can be after a stroke. And interestingly enough, several people commented on how the focus group experience itself was seen as therapeutic, because they had an opportunity to talk with other folks who had been through what they had been through, and to get some, you know, normalization, for lack of a better word, about their experience. And so, you know, I always think, you know, there's really so little opportunity during a hospital stay to help people connect with each other. But it certainly could be something we could integrate into our outpatient services, using support groups and things like that. So what did we get out of this year of collecting data from patients and caregivers about care transitions? So ultimately what we ended up with was a very good picture of bad transitions. So what we should avoid, what didn't go well. So we turned that on its head and developed kind of a model of what we think of as a good transition. So we identified 4 areas that characterize a good transition, and this really came directly from our focus group data. So first, and obvious because it came up in every single focus group for patients and caregivers, was stroke prevention and fear of recurrence. So we want to make sure people, when we're transitioning, have some idea about how to prevent another stroke. Preparedness. How do you manage at home? What could possibly happen at home? How do you prepare for functional changes, but also things like changes in your relationship, changes in your work status? Many people didn't anticipate how long the recovery process would take, so hadn't really thought about the impact on their work life, and then obviously that translates to income. So there were some financial concerns that they hadn't thought about. Getting support, so support for patients and caregivers. This is both practical support, things like finding resources, as well as emotional support. And then identifying unmet needs. So again, tying into the lack of preparedness and the lack of understanding, what are the needs that people are now identifying when they get home? So our next aim was to incorporate these experiences into an intervention. We did that by identifying a social work case management intervention that would provide support over a 90-day follow-up period. Again, using the data we had on some of the other transition programs and identifying that certainly we wanted a longer period with folks. And then we wanted to supplement the social work case management with what we called a virtual stroke support portal, which was a website essentially, which was oriented to patients and caregivers, that really brought together some really good sources of information and ways to communicate and connect with other folks. So we then put this into a trial. So we have a randomized controlled trial with 3 arms. So we're looking at whether we can improve outcomes compared to usual care in a social work program only, or folks who had the social work program plus access to the website. We did this in 3 hospitals. Our initial aim was to have 4 hospitals, but one in the Lansing area had to drop out of the study. So our goal was to randomize 256 patients, and we met that goal on the very last day of data collection, which was 7/31/17, so it's hot off the presses. A little bit about who we included. We really are a practical trial, so we did not want to skim the cream off the top, so to speak. We didn't get just the high-functioning patients. Our patients had to have some disability at discharge. They had to have some stroke presentations on stroke symptoms on presentation. So we did not only get the folks who were relatively healthy. We really wanted our population to mimic the what people see out in the clinical world of stroke. So we did enroll them in the hospital, and we collected data at 7 days and 90 days. These were our primary outcomes for patients. So again, we talked earlier about patient activation or patient engagement. That's one of our primary outcomes, as well as the PROMIS Global 10, which is a quality of life measure. So you can see we have a number of secondary or intermediate outcomes as well. A couple people, I always get asked about the readmission question. So PCORI does not allow you to collect data on cost. So we were not able to collect that data. So somewhat of a proxy, we did 90-day home time and readmissions, and that's self-report. But it will give us some indicator about any cost savings or potential cost savings. Because we worked with patients and caregivers, we had separate outcomes for caregivers. Again, primarily we're looking at strain and burden and depression among caregivers. We worked with Sparrow Hospital here in Lansing and University of Michigan Health Center in Ann Arbor. Those are both certified stroke centers. And then the St. Joseph Mercy Medical Center in Ann Arbor. And our partner, we really had a strong advisory board that helped us every step along the way of the study to make sure that we were relevant to current practice and that we were doing things informed by patients and caregivers. So as well as our patient and caregiver members, we had interdisciplinary professional members from across the state of Michigan. So I'm going to spend a little bit of time talking to you about what the social work case management intervention was. This was, again, available to just 2 of the 3 groups. Group 1 was usual care. Group 2 got social work case management services only. And then Group 3 got social work case management plus website access. Because of time constraints, I won't go over the website, but I did indicate what types of information resources we pulled together there. Our aim was to make it a one-stop shop. So being respectful of the fact that patients and caregivers felt overwhelmed, we thought it would be helpful if they had one place to go to find resources, communicate with their providers, and get education about stroke. So case management consists of a lot of components. Our first and foremost goal is that we want to engage patients and caregivers and build that relationship with them so that they see us as a partner in the transition. We start with an assessment, and this is an assessment we created for the project, which is a biopsychosocial assessment. Case management always includes service planning, which would mean coordinating programs, providing access to services, making referrals, and following up. We provided services to both the patient and the caregiver. So oftentimes the caregiver would have needs that were quite different from the patient, and our job was to help both of them. We included a lot of patient education about stroke, as well as management at home and finding resources. We provide short-term problem solving, so we are not a clinical service, meaning we don't do any mental health counseling and anything long-term like that, but we certainly then help people problem solve if you need long-term services and then make referrals. You see their emotional support, and that includes a range of things. The teaching, planning, and organizational skills, when you think about changes that folks experience after a stroke, sometimes this is a new problem for them, that they were actually quite organized before, and post-stroke they are not as organized. So we did quite a bit of organizational assistance. And then of course we monitor the case, provide follow-up, and document what we're doing. For this particular project, our folks were randomized to the intervention when they went home. So that's when their clock starts. So typically folks got 60 days of intervention. We did have the flexibility to stretch that to 90 based on their needs. So if any of you are familiar with social services, they don't necessarily happen in a 30 or 60 day window. So if we are having to get someone onto Medicaid or medical assistance, sometimes we need to extend up to the 90 days to make sure that that application gets in and processed. So we try to make contact with the patient as soon as they're home, and our aim was to get our assessment done within 72 hours. So again, our purpose is to get in there right away so that we can help them with the transition. We develop a service plan based on what their goals are, and then we provide follow-up as needed based on their needs as well as the service plan, and we help coordinate those services, communicate with providers, and provide different types of support. So we do prioritize several issues because we're patient-centered. The patients really drive what's the follow-up, what are my goals. And we had an interesting conversation last week in our team meeting. Somebody said the only thing he wants to work on is going rock climbing. And I don't really think that's, feasible. And I said, it's not your goal that's important, it's his goal that's important. So how can we help him reach a semblance of that goal? He may not be rock climbing within 90 days, but what are some of the smaller steps we can help him achieve? And we really did stay faithful to this idea that it's what the patients and caregivers want. There were some instances, however, obviously we have to prioritize patient safety. We also prioritize medication problems so that we would intervene if there were concerns about medication management. And we insisted that they receive follow-up from a primary care physician and a neurologist. So those were the times where we kind of overrode what their wishes were. So we're helping in a lot of different ways, and you can see all the types of things that we've done on this slide. And again, it mimics those 4 pillars of a good transition. And I'll just highlight a couple of things under the support. So again, we're not doing heavy-duty mental health, but we often hear from folks that one of the most important things was that they had someone to talk to, that they had someone checking in on them. We do weekly phone calls. We can offer home visits whenever anyone wants it, face-to-face visit. But it really helped them, I think, to normalize their reactions and to hear that someone else had heard this before. So I'm not crazy out here alone trying to figure this thing out. The other thing that we often hear from folks is that they're surprised at how fatigued they are. So a part of our education is helping people understand that fatigue is one of the side effects of stroke. And again, that does help people understand a little bit better about their recovery. I think universally, people want to recover faster than it's happening. So that's a common frustration that we hear, is that, I'm feeling better, but I wish I was feeling much better. And so again, having someone to process that with and problem solve around, listening to their body and taking breaks when they need to, has been an important way that we're helping. In addition, we have identified many needs that existed pre-stroke that folks were not paying attention to, whether they be medical or psychosocial, and I'll give you a couple of examples. So again, we don't have our final data yet, but we certainly have been evaluating feedback from patients and caregivers. So the anecdotal feedback has been positive. They feel that having the social worker involved reduces burden for both patients and caregivers. We provide a lot of stroke education and communication support with healthcare providers. So this could be connecting to services, facilitating services, or empowering folks to be their own advocate in reaching services and ensuring that they're getting what they need. As I mentioned before, we've identified a large array of unmet needs. And again, when we think about the stroke population, you'll notice that many of these are not medical. And I think that's one thing we've learned is that these are complex patients with a lot of different needs. A lot of mental health concerns that were previously not identified. Post-stroke depression is very prevalent. Also anxiety among caregivers we're finding. Financial strain. I mentioned before that people want to recover quickly. And when they can't, they're in a real financial bind if they're still of working age. In addition, many folks have comorbid conditions. And so their comorbid conditions are not being managed. And so we identified some needs that we could help them get connected to more comprehensive health care. Another interesting finding is that many of our folks, although they were patients in our study, were actually caregivers for another family member. And so the stroke has interrupted, again, the role that they had. And for a lot of families, particularly we have several families caring for a disabled younger person. And the primary caregiver is now the patient who's had a stroke. So it really throws the balance off in the family, and the patient feels guilty taking care of themselves. They feel like they're not taking care of their loved one in the same way. So that just adds kind of this another emotional strain layer for folks. So there were several challenges specifically related to the social work intervention, and I'll just briefly go through those. Making first contact was difficult. So we try to call right when people get home. People are getting calls from home health. They're getting calls from the hospital to follow up. They're getting calls from their primary care physician. And so making that initial contact and getting connected was a challenge. People are just overwhelmed at home. So the idea of another person, although we're there to help them, can be just too much for folks. As well as this, there's a segment of the population for whom it's very difficult to accept help. So upon returning home, they realize, like, I'm really struggling, but they consistently just want to try it on their own. We really identified for many people, and those of you in healthcare will understand, just the fragmentation within our healthcare system. And that's something that patients do not understand. So many folks assumed that I was in the hospital, I had a stroke, someone told my primary care physician they should be calling me, or someone told my cardiologist. And so they have this impression that the system actually communicates with each other about them. And, those of us in healthcare know that that rarely happens. And so that was a frustration for them. And in addition, some people had psychosocial challenges that predated the stroke that were daunting. Again, some of these psychosocial needs that we identified were an income or financial strain. So we did help people with getting on disability, both short and long term. Finding some assistance paying for their medical bills, and many hospital programs will have some financial assistance, and most patients are not aware of that. We also, for a number of patients with private insurance, they faced a real barrier related to cost of occupational therapy, physical therapy, or speech therapy, that if they were outpatient, they had a copay for each of those services on each day. So I just put an example there. If you were to go to those services 3 times a week, your copay would be $180. And so for some people, that was just way too much. They could not manage that. And it meant making the choice between getting therapy, which is really essential to their recovery. We did a lot of referrals to food pantries. So again, if you're familiar with geriatric care, we know a lot of our older patients forego feeding themselves to pay for medications and other things like that. So we again saw that in this population. In addition, medical coverage changes, so helping with getting on medical assistance or applying for medication assistance through the drug companies. Transportation, always an issue, so we helped a lot with transportation. And then we just found in our particular geographical areas, there's a real lack of housing resource and home repair resources. So those were some of the things we had a challenge helping people with. So one of the ways we're trying to get information out about the project and out about how to improve care transitions, we developed a couple of tip sheets that we will provide to outpatient services and primary care offices, as well as patients and caregivers, to help them communicate better with health professionals, as well as anticipate some of the common reactions to a stroke once you get home. So as I said, we just finished enrolling our most recent patient in the end of July, so we're still collecting data. We're hoping to have our primary outcomes data coming up in the winter of 2017. However, we're doing some work in the meantime, such as talking to folks like you about what we've learned and creating the tip sheets and some of the educational material. We really would like to share what we're finding about how to improve these transitions and how we can leverage this to improve patient care, because ultimately that's our goal. So I appreciate your time. I'm happy to take questions. I do have the tip sheets. I'm not sure if, can they see my screen if I open them up? Okay, so I wasn't sure we would have time, so I didn't show you, but we do have, I just want to show you what they both look like. And we had our advisory group help us put these together. So you'll see that they only go across the page. We had a column format, and one of our occupational therapists said, no, we train people to read all the way across the page and then come back. And if you have certain visual deficits after a stroke, people can't see things that are in a column formation. So they basically miss either the left or the right. So we changed our organization. And again, this will be a repeat of some of what I told you, but here we're helping them figure out, how do you keep track of things and stay organized? What are some of the physical and cognitive changes or limitations you'll experience? And again, we highlighted fatigue because we have heard that so much in the field. A lot of it is helping people be kind to themselves and be aware that recovery is such a versatile path for everyone. So that's the one about anticipating what's going to happen at home. And then the other one is communication with healthcare providers. Let me see if I can get that. So again, this addresses the idea that people, sometimes our care is fragmented. So what should you make sure you leave the hospital with? What you should do when you leave the hospital? Things to bring to doctor's appointments. So again, practical advice. That we thought would be helpful to folks when they get home. I'm happy to take questions. That's my email and my phone number if you want to reach out to me. We also have a study website that has some of our other materials on it. But I really appreciate your time, and hope that sparked some interest and gave you some ideas about things you could do in your own practice to improve care transitions.
Okay, so we'll now take questions and comments. So if you have a question, please ask, or a comment, please feel free to unmute your mic and ask our presenter.
Victoria, it's Cindy from Tawas.
Yeah, go ahead.
The survey for today has got the September 20th information on it.
Okay, I'll fix that when I get back to my office.
Thank you.
Are there any other questions or comments for our presenter? Okay. If we don't have any questions or comments now, please feel free to indicate them on your evaluation once I get that fixed. Or you can feel free to email them directly to Dr. Hughes or myself, and I can pass them along to her if you email them to me. We'll go ahead and sign off. And once again, thank you for being patient with us earlier when we were having technical issues. Thank you again, everybody, and have a great day.